If someone presents with hyperphagia, they give a patient with hyperphagia, hypersexuality, hyperorality, hyperdocility. What's the most likely diagnosis?
That is the it is a lesion in the mammillaries.
Is it mammillary?
Yeah, I don't know. That is Kumba.
Okay, good.
Oh my God.
Kluver-Bucy syndrome,
Good word, good word.
right?
Yeah.
That is Kluver-Bucy syndrome. Kluver-Bucy syndrome is as a result of bilateral damage where?
Yeah.
In the amygdala.
Amygdala. Oh. Yeah. My library is about the alcoholics.
Good. Mammillary body lesion is in alcoholics. What exactly? What vitamin deficiency results in damage to the mammillary bodies?
Vitamin 1, vitamin
Vitamin what?
1.
One vitamin.
Vitamin
What's vitamin 1? B1, right?
0.
Vitamin B1. That is thiamine.
Yeah.
The deficiency in thiamine. What's this disease or this condition called? When you have bilateral damage to your mammillary body and also damage to the dorsal thalamic nucleus. This is less spoken about, but it's a thing, and I think it's also in your first aid. Dorsal thalamic nucleus. What's this disease called?
It's not Wernicke. Oh, yeah.
Yeah, that's it, right? Wernicke-Korsakoff syndrome, right?
Yeah.
You can say Wernicke encephalopathy, Korsakoff psychosis, doesn't matter. Wernicke-Korsakoff syndrome. How did we say we diagnose people with thiamine deficiency?
So, deficiency, one, it's about the enzyme transcriptase.
Good. We look for decreased activity of ROBC transcriptase. Decreased activity of ROBC transcriptase. Do you get that?
Yeah.
Of course, B1 deficiency causes two other diseases. What are the two other diseases that can be caused by B1 deficiency?
Very
Beriberi, whether wet or dry. What makes wet very wet? They have heart failure and symptoms of heart failure. What makes dry very dry predominantly? They just have peripheral neuropathy. You remember that?
Yeah.
All right. If a person presents with hyperreflexia, hypertonia, and positive Babinski sign,
It's a upper neuron.
upper motor neuron damage, what tract is involved? What tract do we refer to as the upper motor neuron here? Where's the tract coming from and where is it going?
Cortical.
Good. Go ahead.
Cortical spinal.
Cortical spinal. We said in neuro, all you have to remember is really the anatomic location. Where is it coming from? Where is it going? It's coming from the cortex and it's going to the spinal cord, so it's the cortical spinal tract, right? Cortical spinal tract lesion is, at least for your exam purpose, what we refer to as upper motor neuron lesion. We have other upper motor neuron descending tracts as well, right? But predominantly we are talking about the cortical spinal tract. All right. How do people with lower motor neuron damage present?
So it's gonna be the opposite. It's like up hypertonia.
Okay, so it will be hyporeflexia, hypotonia. What else? Atrophy of muscles, fasciculations. right? Remember that these people have flaccid paralysis. And these guys who have spastic paralysis. These guys have flaccid paralysis, whereas people with upper motor neuron damage will have spastic paralysis. People with upper motor neuron damage may develop atrophy over time, but it's going to be atrophy of what? Disuse. So a long time after they have the lesion, after they've been paralyzed for so long, because they're not using the muscles, right? Then they may develop atrophy, but over a very long period of time. So we generally don't think of atrophy as part of upper motor neuron damage, even if it can occur. Does that make sense?
Yeah.
All right. If they give a patient with hypoxemia,
Okay.
polycythemia, and hypercapnia. Hypoxemia,
Okay. We are talking
poly.
about it's a obstructive disease, respiratory disease. So it is a chronic, no, EPOC, chronic. Sorry, what do we call it? Chronic bronchitis.
You go with what you think. If you think of it, it's probably correct. Chronic bronchitis, right? This will be chronic bronchitis. These are the people we call the blue bloaters,
Mm-hmm.
right? These are the people
Okay.
we describe as the blue bloaters. What's the pathophysiology of chronic bronchitis? What's going on here?
So it is the bronchitis. So it's a chronic like inflammation of the bronchioles, and it's this they say the index that is about the
Okay, they have increased read
muscular,
index,
yeah.
but why do they have increased read index?
Mm,
They have a hyperplasia of mucous glands. Okay, they have mucous gland hyperplasia. Mucous gland hyperplasia. Because they have mucous gland hyperplasia, they produce a lot of mucus. This becomes a breeding ground for bacteria and they develop recurrent infection, right? They
Yeah.
develop recurrent infection. We have a definition for chronic bronchitis. You do if you do in clinical medicine. So we talk about cough for 3 consecutive months in 2 consecutive years, right? They'll have cough, productive cough, for 3 consecutive months in 2 consecutive years. That definition does not necessarily help you diagnose it on your exam, but you should know that there's such a thing, right? These people are, what happens to their pulse oximetry? Is it pulse oximetry or their pulmonary function test? What do you see on pulmonary function test?
Because it's obstructed, it had to be the decrease the FEV. This is the
Decreased FEV1. Of course, they also have decreased FEV1 FVC ratio, right?
yeah.
Everything is decreased. What's the difference, though, between chronic bronchitis and emphysema?
Emphysema. Is normal this parameter?
What is normal in chronic bronchitis?
The
The DLCO is normal.
they assert.
In chronic bronchitis, you have normal DLCO. In emphysema, you have decreased DLCO.
Emphysema. Okay.
In emphysema, you have decreased DLCO. Do you get that?
Yeah.
Okay, they give a patient with indurated ulcerated genital lesion. Indurated ulcerated genital lesion. What comes to mind?
So
Indurated ulcerated genital lesion. Yes.
it is it's hemophilus ducreti.
Hemophilus ducrei. Okay.
Mhm. That is in my mind.
What's the other one you think about? What's the second one?
Sorry?
What's the second infection that would cause an ulcer on the genitals?
Herpes.
Herpes will be more, whenever they want to ask you about herpes, they will describe herpes as vesicular lesions. Do you get it?
Yeah.
Whenever on your exam, whenever they describe vesicular lesions, you think herpes. Almost all the time. Almost all the time. There is one place where they could describe vesicular lesions and it might not be herpes, but I think it's pretty obvious. It's when people have vesicles and ulcers in the throat, and then they have lesions, rash on the palms, fingers, and soles. You see that? They may also have presentation or signs of myocarditis. What is this virus? What's the virus that causes this presentation?
That is Kawasaki.
Kawasaki. Kawasaki is not called by a virus necessarily. They sound alike, but it's not Kawasaki. Rash on the palms and soles. Okay, before we come back to that, give me the causes of rash on the palms and soles.
So we have palms and soles. I got to forget. No, it wasn't known.
Causes of rash on the palms and soles, yes.
I'm thinking. Right now, I don't know. I forget it.
Coxsackie.
What was it?
Not Kawasaki, right?
Kawasaki.
Coxsackie B virus. What else?
Lyme disease.
Lyme disease. No. Rickettsia rickettsii.
Rickets.
What else? Secondary syphilis, right? These guys will cause rash on the palms and soles. Do you get that? Infectious agents. So which of these guys now will cause myocarditis? Whenever they give you someone with myocarditis, it's almost always viral in etiology, you have to assume. And there's one virus you have to always think about, and that would be Coxsackie.
I think that was it. Okay, yeah.
You get it?
Yeah.
That would be Coxsackie B virus. All right. And Coxsackie B virus causes hepangina. But don't worry about this right now. That's not big on step one. Indurated ulcerated genital lesion. You think of your Haemophilus ducreyi and you think of secondary syphilis. You think of secondary syphilis. And you treat secondary syphilis with what?
Penicillin.
Penicillin. What is the reaction that people get after they are treated with penicillin?
Reactions. If we call the treponemas.
Yeah. When you have lysis of the spirochete and release of their toxins, what do we call that reaction? That was Jarisch hexymal reaction, right? Jarisch hexymal reaction. You want to remember that. What's the difference? So both secondary syphilis and Haemophilus ducreyi would produce ulcers on the genitals, right? What's the difference between the two, though?
It's painless and
which one is painless and which one is painful?
So, Hemophilus ducrei is painless.
Painless. Hemophilus ducrei would make you cry. Hemophilus ducrei is painful, and secondary syphilis is painless. You get it? What's the pathophysiology of syphilis? You have to know this. What's the pathophysiology of syphilis? How does syphilis carry out almost all its activities?
What is
That is thromboangiitis, obliterans. Thromboangiitis, obliterans. Do you get that? Basically,
Yes.
it destroys tiny blood vessels. If you remember syphilitic iotitis, where syphilis destroys the vasa vasorum, it destroys the blood vessel to the blood vessel, the blood vessels that supply the thick wall of the aorta. And by destroying those blood vessels, it weakens the walls of the aorta, right?
Yes.
All right. So the pathophysiology of syphilis is going to be thromboangiitis obliterans. Okay. Remember that penicillin in treating syphilis can result in Jarisch eczema reaction, which is basically that these people are going to present with flu-like symptoms, right? Myalgia, mild headache, and whatnot. Do you get that?
Yeah.
All right, they give you an infant with cherry red spots on the macula, hepatosplenomegaly, and neurodegeneration. Cherry red spot on the macula, hepatosplenomegaly, neurodegeneration. Okay, before we even get here, give me the list of conditions. There are 3 of them we've talked about that would cause cherry red spots on the macula. Just go with what you think.
I'm trying to remember the chapter there.
Okay.
Goucher?
No.
No, Goucher is the pathological. Yeah, it is the Tasha.
Tay-Sachs disease. Okay. Tay-Sachs. What else?
The other one that is the last one, Harler, maybe.
No. No. You were saying it before. Niemann-Pick's disease. If you think about it, you have to trust that you are correct and allow yourself to say the word. All right. Tay-Sachs disease, Niemann-Pick's disease. What's the third cause of cherry red spot on the macula? We talked about central retinal artery occlusion. Central retinal artery occlusion. Now, we have the 3 of them. So if I give you a patient with cherry red spot on the macula, plus or with hepatosplenomegaly and neurodegeneration, what would it be specifically?
I would think about this is Niemann-Pick because that shack they don't have a pathology.
Exactly. This would be Niemann-Pick disease because in Tay-Sachs disease there is no hepatosplenomegaly. Very important. I said everything related to Gauchers is bone, bone, bone. They'll have bone crisis. They'll have pancytopenia. They'll have bone pain. Right? What enzyme was deficient in Gaucher's disease?
Gaucher is the first one. Exosaminidase.
No, not hexosaminidase. The first one on the list was actually Tay-Sachs, not Gaucher's. Gaucher's was I think almost the last one. So for Gaucher's, everything is GGG as well. Gaucher's disease.
So glucosero,
Very good.
glucocerebrosidase. Glucocerebrosidase.
Glucocerebrosidase. And what was accumulating?
The other one is the gluco, the same
Glucocerebroside. Glucocerebrosidase, when you study, you have to pronounce the words as often as possible aloud, not in your mind. You have to say them aloud so you get familiar with them, right? So glucocerebrosidase is deficient, glucocerebroside is accumulating. Gaucher's disease. In Tay-Sachs disease, what was the enzyme you said was deficient there?
Okay, yeah, then the exosaminase.
Hexosaminidase.
Mhm.
Hexosaminidase A, and what is accumulating?
The GM2
Very good. GM2 ganglioside. How about Niemann-Pick? What was deficient?
brown voucher, so it's different. It's sphingomyelinase.
Very good. Sphingomyelinase
Um,
deficiency. And sphingomyelin, of course, is accumulated, right?
yeah.
And then for hunters and haulers, you remember that hauler syndrome were the ones with the cataracts, right?
Yeah.
And hunters did not have cataracts. L-iduronidase deficiency, right?